First of all, I changed the title a little bit because this is too long. But I like to think about innovation, which is what I'm going to talk about, as first finding it. You have to detect it. And then what we tend to do where I work at Institute for Healthcare Improvement is we do something called harvesting, which really is not the full thing. What you need to do is to notice it, harvest it, and then you do some winnowing and you throw out 90% of it and keep the best grain, and then you have to test, implement, and scale it up. So it's really a long process, and by lengthening the title, I tried to give some sense that it's not so simple. I have no conflicts of interest, actually, yet to talk about. I'm post-board whatever, so anybody that has a board position, apparently if you're on a board of a large pharma company, you earn hundreds of thousands of dollars, and I'm willing to be considered for such positions so I can put something on this slide. It is amazing if you read about what Sloan Kettering is going through. I said, what have I been doing all my life that I missed this pathway to a gated community? And here are my objectives. I've learned a lot from my nursing colleagues that you really ought to have educational objectives. So this is what, if I'm successful, you will be able to do or know when you leave today. So that's basically a roadmap for the presentation. And you can tell me at the end whether you feel that you have self-efficacy or competency in any of these areas or not, and that'll be my feedback. First of all, improvement science is intuitive and practical, and I want to just give you a little background about all the terminology that exists. So Institute for Healthcare Improvement does what we call the science of improvement or improvement science, but look at all these other terms here. Healthcare delivery science was a term that Jim Kim, who's now the head of the World Bank, started using when he was at Dartmouth. Implementation science, which I'll take a couple of minutes to talk about. System strengthening, systems engineering, and now, thanks to people like Lucy, we have Learning Health System, Journal, and a Society. So that's another science. And then we have all these methods. At IHI, we teach the model for improvement, which I will, in fact, teach you in 7 minutes, actually. That's how long it takes to teach it. Lean Six Sigma, et cetera, et cetera. The point is that all of these disciplines are very similar, come from the same roots, largely from industry, and the fragmentation of these fields is, I think, lethal. My theory is that people in academia like to invent new terminology because then they can publish a paper on learning health system science or whatever. And then if they're really good, they can get promoted, and then they can start a journal and get promoted again, and then they can form a society and start having international meetings, which then shows they have international influence, and then they can become a professor. And I'm not kidding, I think that's what's motivated some people to come up with all these different terms. I do want to talk about implementation science, because this, not improvement science, this is the term that has become the federal standard. So if you write a grant or you want to start a meeting and you don't use the term implementation science or dissemination and implementation science, you won't be considered to be using the right terminology. So for a long time, I preached, being an Institute for Healthcare Improvement person, that this was absolutely indistinguishable from improvement science that we teach at IHI. And I no longer think that's correct. The three things I want to emphasize that are truer of implementation science than what we do at IHI is, first of all, implementation scientists really talk about implementation outcomes. And I didn't know what this was till I taught a course at Harvard School of Public Health on implementation science as a guest lecturer, and the students asked me stuff about type 1 and type 2 hybrid studies and implementation outcomes. I had no idea what they were talking about. So I'm going to show you a slide about that in a minute, but that is a little different than what we do in improvement. There's a real emphasis on context assessment, and we'll spend a lot of time on that this afternoon. That's really, again, not something unique to implementation science, but is really emphasized in that field. And then in general, implementation scientists are a little bit more devoted to behavioral science and to clinical trial designs that are more or less randomized, where they're really focused in on what the counterfactual is. If there are those who don't know what that technical term is, it just means what would have happened if we hadn't done anything. It's a way of thinking about secular trend. So those are really different, I think, in terms of emphasis. These are all the manifestations of implementation science: a journal, an international society, a meeting in Washington, a meeting that's, I think, in Europe somewhere going on right now. So it's a whole field. This is a short definition from a couple of the thinkers in this field. It's really very simple. It's not really fundamentally different from what we talk about in quality improvement, but that's a useful definition. And these are the implementation outcomes. And I'm not going to go over this slide, but I want to make a point, and you can study this later. These are really useful to think about. For example, fidelity. The degree to which an intervention is replicated precisely as intended is something that we don't talk about much in improvement science, but is a key measurement or key outcome in implementation science. Penetration, to what extent is it really integrated into the service, so it's not something you did as a research project? Is it really integrated into the way you work? And these are really useful, but in fact, they're not that original to the way we think about healthcare. Recently, one of my fellows used the re-aim framework, which is used a lot in public health. And if you look at that, they talk about reach, effectiveness or efficacy, adoption, implementation, and maintenance. Those parameters are not that different from what people talk about in these implementation outcomes. So the bottom line for me is that there are only so many ways really to describe these common themes, and we shouldn't get all hung up about them. They're really intuitive, and they're common sense. Now, so what do we teach at IHI? We use this book, The Improvement Guide. I am not a shill for selling more copies of this book, but it is given out to everybody who takes an expensive course at IHI. You get this book. And it is the fundamental thinking about our methodology. And now what I'm going to do is to tell you everything you need to know about this in 7 minutes. So this is the origins of improvement science. It comes from these great thinkers like Juran and Short and Deming. And those of you who've taken courses in improvement science know these icons. And generally in IHI courses where we train people in this, the next hour would be spent kowtowing and paying obeisance to the great founders of improvement science at great length. I'm not going to do that. It's really very simple. The one thing you don't do, though, you notice that Deming called this profound knowledge. All this profound knowledge stuff boils down to 4 pillars. And the 4 pillars are really important. First of all, theory of knowledge. What is that? The technical term is epistemology. It's just how do we know? How do we learn? And in quality improvement, how do we learn is generally rapid cycle tests of our theory in practice. That's all that really is. Understanding variation. There are 2 kinds of variation. Variation over time. One of the key features of improvement work is that we analyze by looking at what's happening over time in a very graphic, intuitive way. And how do we know the change we're seeing is really significant? Have we significantly improved things, or have they deteriorated significantly, or is it all random noise? And that's variation over time. There's also variation among. So people are always fond of pointing out what the bright spots are, and that's because we want to learn from where there's variation among institutions, health systems, wards, doctors, nurses. We want to understand. We want to learn from the best and avoid the mistakes of those who have not thrived. So that's 2 kinds of variation. Appreciation of a system. If you don't understand the system for getting work done, either here in this center or on a hospital ward or in a clinic, then how can you possibly know where it needs to be improved? And how can you possibly know where it needs to be monitored to ensure that whatever you've changed is actually being performed and sustained? So that's all appreciation of the system is. I was recently working with a Vermont-Oxford neonatal ICU network that has got thousands of members around the world, and we're working on antibiotic stewardship. And I went and I was coaching them on improvement. I looked at I would say 150 posters on antibiotic stewardship. I didn't see one system diagram. And if you can't draw your system, you're really, as far as I'm concerned, you shouldn't be starting your work. And then psychology, how do we change human behavior? And this obviously is an area that we can learn a lot from behavioral economists and behavioral scientists. And sometimes I think in the improvement world, we're not serious enough about what these folks have to teach us. This all leads to this model for improvement, which you've probably all seen. It's pretty widely disseminated. It simply says, what are we trying to accomplish? What is our goal? How much do we want to improve? For whom and by when? It's really simple. A good goal is not the Boston Children's Hospital, where I work, goal till every child is well. I mean, that is not an improvement goal. That's some aspirational vision of the world. I don't even know if we ever will make every child well. I want to know, can we improve the rate of absenteeism for asthma in the Roxbury school system by 20% by 2019 or whatever? I want it to be that specific, and then it's actionable. How will we know change is improvement? What's our measurement framework? What processes of care are we going to measure that are tightly linked to the outcomes we hope to achieve? In the case of the asthma example, it may be taking your corticosteroid, inhaled corticosteroid, or using your inhaler appropriately or whatever. What changes can we make? These are the great ideas you have that you want to test in real time. And then the fundamental thing are these so-called Plan, Do, Study, Act, or PDSA. This is really just experiments. I have a theory that if I ask the school nurse to go from class to class showing students how to use their inhaler, they will use their inhaler more often. I can test that tomorrow in the 5th grade classroom in one day, and I can study to see whether anybody uses their inhaler properly the next day. That is a planned the study, I did the study, and now nobody changed their behavior, so I'm going to try bringing in a priest. And that's my next experiment, to teach them how to use the inhaler. These are done in rapid time. What I see all the time is plan, do. Plan, 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 implement. 6 months later, it didn't work. That is not in the spirit of rapid cycle PDSA testing. So that's all this is. It's you have a theory, you make a prediction, you see whether or not it works in practice. And this is the single slide that summarizes everything you need to know about improvement science. Clear, measurable aim, how much, for whom, by when, understanding the system in which you're trying to reach your goal, where it can fail, where there's inefficiency and waste, and where it needs to be improved and then monitored to make sure you're still doing what you said you do. Be very clear about the predicted impact of the changes you're going to make on the outcomes. I'm going to pause on this for a second. In quality improvement, I almost never see somebody say that if what example can I give you? If I take razors out of the operating room, which now we all do, because I know that if you use a razor to shave the operative site, you increase your risk of an infection. If I take them out, I will have an improvement in my surgical infection rate. And hospital, you need to support me to do this, because I think this is, look at the evidence. I've got 5 papers here that show. Well, what is the attributable impact of that change on surgical infection rate? So in other words, if I do this and this alone, how much of a change can I expect from taking razors out of the OR in the overall infection rate? And most people think it's a lot, but it's actually under 2%. It's under 2% because you have to do 15 other things that are evidence-based, and you don't even know about all the stuff that you don't know you need to do and can't be measured. So we always overestimate the attributable impact of the changes, and I'd like to see improvers every time say, I think if I do this and it's reliably implemented, which is a big assumption, I will see a change of 1.5% in the surgical site infection rate. So that's a discipline we need to have. Then separate this from the implementation plan. What are the activities you're going to do, and what do we expect to happen? I'm giving you a lecture. I'm really trying to be animated and entertaining, and a little bit edgy. And at the end of the day, you may enjoy this and have a great time and say, gee, Don was good, he's distinguished, just like Lucy said. But the chances that you'll go and do things different are close to zero, because we know a single lecture is extremely ineffective as an activity. So if you're going to do an activity, what do you predict is going to happen as a result of that activity? And improvers are too vague about that in my view. Learn from continuous testing or experiments, those PDSA cycles. Track improvement over time to see if there's a statistical change or variation in your outcomes, and compare your performance to the performance of others so you can learn from that kind of variation as well, and then understand how to change human behavior. And that's it.
That's pretty good.
That's all there is. I mean, that's all there is to it, honestly. And there are nuances and detail, but if you can just be rigorous about doing those steps, you'll be far ahead, I think, of where most people are when they do improvement. I actually won't be talking about this, but I have a belief that quality improvement that is not well enough designed so that you can really learn from it is unethical. You know, we go talk about institutional review boards and so forth. Why would you subject somebody to an experiment that is designed so poorly that it's impossible to learn anything from it? And I'd say the vast majority of quality improvement projects I see are exactly that way, and they waste time and money and will, and they sap the energy out of improvement, and eventually it goes in the dustbin of history as another idea that didn't pan out or help the health system. So fortunately, I spent over 10 years working in a laboratory trying to develop a vaccine for Staphylococcus. You know, MRSA and staph's a big issue in healthcare, on football teams, basketball stars, all suffer from staph infections. So we had a theory that if you extracted a molecule from the cell wall of Staphylococci, which is called PNAG, I won't give you the full chemical name, and injected it into animals, those animals would make antibody that would essentially kill the invading staphylococci. We call these opsonophagocytic, which means to prepare to eat in Greek, because they would bind to the bacterium, and then white blood cells or neutrophils would recognize the fact that they could gobble up the staphylococci that the antibody had attached to. That's opsonophagocytic antibody. So what did we do? Well, we had this pure chemical, and now we had a theory that if we inject it in animals, they will make antibody. We did, I would say, 20 or 30 or maybe 40 litters of rodents to try and find the right dose by the right route to get an antibody response. Subcutaneous, intramuscularly, intravenous, stab them in the heart. I mean, all under humane animal conditions, I promise you, until we found the dose that we could actually reliably get a good antibody response. And then we did many experiments to show how in a test tube we could demonstrate it was opsonophagocytic and actually killed staphylococci. Then we had to say, well, how do we know this actually prevents infection? Endless numbers of experiments to find a way to make a rat get an abscess so that we could show we could prevent it. Rats live in sewers. Very hard to get enough bacteria in a rat so that it actually gets an abscess. All of this is theory, prediction, plan, do, study, act cycles where every week we're looking at the results of our experiments and deciding what our next one will be. This is absolutely no different than improvement science in my view. Now, you're saying, because you're clinical, right? Are you clinical?
I do have a clinical background.
See, your clinical background. I'm good. It's Nostradamus here. So clinical background, and you're saying, well, on the wards or in the clinic, it's not like an animal lab, right? And you're right to a point, but for example, it does matter what's going on in the animal lab. If you handle the rats roughly, they will be more susceptible to staph and harder to protect. If you give them the wrong chow, or you have uneven temperature in the lab, or you get them from a different company, even though they're genetically pure, the results vary. So actually there's a lot of contextual factors in the animal lab that are playing on the results of your experiment, and you better take account of that. Now you're saying, but that's the animal lab. It's not like my ward where I've got all these complexities and psychology of safety and all this stuff we talk about and good communications. So in this laboratory, I'll tell you, the PhD working there is a brilliant guy, he's a good buddy. But he likes, or I don't think he still does, I hope, he liked to tell jokes which I regard as sexist. And so I would try and tell him that this was not wise, since his laboratory was, I'd say, 90% made up of pre-docs and post-docs who were female. And I can tell you the environment, my main role there, since I'm not a real scientist, I'm an epidemiologist, was not so much to guide the experimental work, but it was to provide an intermediary where I could get feedback from the lab and tell him when his theories really weren't working out so well and that maybe he was cherry picking the data or whatever it was, because there was no psychology of safety in the laboratory because he told these jokes. So these principles are general. They are scientific, and they're not just some soft stuff that improvers have dreamt up. Most talks that I listen to by improvement people start out with the healthcare system is broken, and they'll say accept at KP or something like that. And then I go talk to people at KP, and they'll say, well, yeah, it's really great, but just not everywhere. There's all this negative stuff, and I'm an optimist. I don't want to wake up every morning feeling desperate to save the world. And so I've just listed stuff here that in my span of years in healthcare have made me excited and made me always want to start with something positive. And you can read these, but some of these are amazing. When I was training in pediatric infectious diseases, kids would come in all the time with Haemophilus influenzae meningitis and end up either dead or with severe brain damage or deaf or whatever. We never see this disease anymore because we've developed a vaccine that prevents it. I thought that, I don't know if I have it up here, sleeping sickness, I didn't put that one in, but just a few weeks ago, sleeping sickness, which affects millions and millions of people in Africa, in order to treat that disease, you had to cart in volumes of IV fluid and give toxic therapy intravenously. And if it gotten in the brain, it was really not a very successful therapy. And now we have, I think it was 10 days of oral therapy and you cure it. Now, I don't know how we're going to pay for it anymore. We're going to pay for 12-week oral therapy for hepatitis C in all parts of the world. But the fact of the matter is, I would never have dreamt that we would have an oral therapy for hepatitis C, or cure sleeping sickness with oral therapy, or eradicate guinea worm or polio, or any number of diseases we're really beginning to eliminate. So let's feel really good about it. And I'll just say this as an aside, and this is the kind of story you may want to stop, but I have improvement colleagues who will show me, for example, how the rate of remission and for inflammatory bowel disease, Crohn's disease, colitis, has improved radically, and how hospitalizations due to inflammatory bowel disease have dropped radically. And they'll talk all about the improvement collaboratives and learning health systems that have made this happen. The fact of the matter is that those radical improvements would not be possible without biologic drugs that truly alter the course of the disease, as opposed to paper it over the way corticosteroids did. And never do they show on those beautiful charts where those discoveries were made. Yes, improvement people, learning health systems, have a major role in spreading the adoption and safe implementation of those biologics, but it wouldn't have been possible to do that without those biologics. In my own infection control life, when I was in training, we put hard plastic polyethylene catheters into people's veins, and they got infected all the time. Why? We didn't really understand all the things we should do to prevent infection, but these are traumatic catheters that abraded the vein, caused clotting and inflammation, and paved the way for infection. Now we have silky smooth silicone, blah, 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 with hydro, whatever, and they're just better catheters. And so, getting to zero for central line infections with infection control bundles is now possible, whereas it would never have been possible when I was in training. Trust me, it just wouldn't have happened. So let's talk a little bit about detecting those innovations. Where do they come from? And I've just summarize this, they come from research and industry, rapidly evolving innovations in technology and smartphones and so forth. They're hard to evaluate. It's a challenge for you guys. How do you evaluate a moving target? So an example, there was a study called the PROMISE study that was looking at telehealth for heart failure. It was published in New England Journal, showed no impact. By the time that study was published, telehealth for heart failure had moved way beyond that simple intervention that they tested in that randomized clinical trial. And even today, it's hard to keep up with advances in remote monitoring and remote health promotion because they're changing all the time. We're innovators, the apps change, the monitoring changes. I've already talked about the synergistic effect of these advances in QI. I'm going to talk more about disruptive innovation. We'll talk about positive deviance. A lot of innovations come from resource-constrained countries. Nothing like constraint in resource to make people into innovators. My friend and colleague Sir Nigel Crisp calls this the world upside down. He doesn't like reverse innovation. It implies a gradient in superiority, which I think he's right about. It's really, you learn from everywhere. And then, of course, you learn from the front line of care. So here's some examples of innovations under constrained conditions. First of all, facilitated women's participatory learning and action groups, fancy term for a learning health system among mothers. I actually have a picture there of the mothers sitting in what they actually called a quality circle, trying to figure out how to prevent their babies from dying during childbirth. This was tested originally in Nepal and now fairly widespread in India and other countries, and looks to be a very effective ways of mobilizing innovation and implementation of evidence-based practice by mothers in diverse contexts in very, very constrained conditions. By the way, even though there's a huge shortage of healthcare providers in the world, this stuff is all carried out by lay people who've been trained centrally, now supported by remote smartphone communication. But they're not all trained medical providers who went to nursing or medical school. Do you know what plumpy nut is? So plumpy nut is basically peanut butter. And it turns out that it's extremely high caloric and is extremely effective for treating severe malnutrition. And some idiot decided to add antibiotics to that, which as an antibiotic infectious disease guy drove me crazy. But it turns out if people have kwashiorkor and are really dying of malnutrition, infection is what knocks them off. And by adding amoxicillin or oral ampicillin to the plumpy nut, they reduce mortality somewhat dramatically in those children. So again, in innovation, you have to be willing to risk and fail, and we'll talk a little bit about that. Sunflower seed oil on newborn skin apparently increases survival in adverse conditions. Taking a sari and filtering water is a good way to prevent guinea worm transmission. Aravind Eye, we were talking about, I think, briefly yesterday, is a faith-based initiative in India where a very spiritual person interested in healthcare was tired of seeing millions of people in India blind because of cataracts, and gradually using lean methodologies figured out how to get cataract repairs done extremely cheaply to hundreds of thousands of people in India with outcomes that are as good as they are in the national health system of England. And by the by, he also figured out how to make intraocular lenses that cost only a few bucks as opposed to the hundreds of dollars you would pay before he figured this out in the United States. The Holt Prize is interesting. You probably haven't heard of that. This is a businessman who has a business school, international business school, who has an annual prize of $1 million. And groups of students or young people compete as teams. And every year there's a challenge like, how do you educate people in slums in the poorest parts of the world? And the teams have their innovative ideas. Those who are shortlisted are trained over a couple of months in Boston with coaches on the finances and scalability of their idea. And then they present at a pretty fancy event that I went to one of them. Bill Clinton was there, and a Nobel Prize winner and so forth. And the 5 finalists get up and do their pitch. And this is where I learned that being able to pitch is of paramount importance. We don't train young people how to pitch. And it also teaches you love. This is another one of those stories, but the teams were pitching and it was great. One of them had a collapsible school using the Montessori design that you could use in Barrio and Sao Paulo and so forth and so on. And then a team gets up there, I can't remember which team it was, and they're going through their pitch and it's great, the graphics, the optics, the thing. And this guy gets up there and he chokes. He literally can't get the words out of his mouth. And you can just see that all these were sitting there, drinking actually pretty decent wine, let's see, with our canapes or whatever. And the guys choked, and everybody's, and I was waiting for, everybody to do this. The team came over, and they put their arms around the guy, and prompted him like you would if you were in a theater and somebody forgot their lines, and he got through it. And they didn't win, but they didn't win for lack of love. It was so, to this day, I just remember that if we could just treat our colleagues who are palpably failing or choking or whatever, it would be great. I wish somebody had done that when I was growing up. I'd probably be a better guy. So always look to the front line. That's the first place to go. And you want to look for the pain. And here's another story that I hope will instruct you on how you might engage clinical people. How many people are clinical, see patients? So, a few of you. So, an academic who sees patients. That's good. Yeah. So here's an example you'll resonate with. I was the new medical director of quality improvement at Boston Children's. We put together a little quality improvement team with a fellow from Spain named Montserrat Vera. We developed, despite all you hear about the checklist manifesto and who invented the checklist, we developed a requisition that a checklist with the 6 things that a radiologist or an ED doctor would want to see before you're justified in the evidence-based CT. And so the requisition now comes, it has the key clinical information, and by the way, they're not getting as many CTs because they're seeing when they fill it out that the kid doesn't meet criteria, and we got it published as an academic paper, interprofessional, everybody was happy, we improved care, I got promoted without naming it something else. But it just goes to show that, that identifying pain's important. You ought to at least try to align with institutional priorities. We were talking about this earlier, that when you're looking for pain and asking for the front line to tell you what they need help with, you don't want to shut off people who come forward by picking certain projects that are most aligned with institutional priorities. I was just saying to the team earlier that even if all you do is to have a cup of coffee with the losers and just say, I really appreciate the problem, maybe I can give you a little coaching on the side, that just pays huge dividends because then they'll actually think you care about them. Harvesting intrinsic motivation goes without saying. People really come to work because they want to do better. Carving out protected time is tough. I don't know what the KP practice is, but in industry, it's pretty much assumed that a good fraction of your time is going to be on innovation, and in fact, the budget will support it. So at IHI, I was in charge of innovation and research and development, and I wanted to calculate how much we devoted, and IHI thrives on innovation. It was about 1% of our gross, and that just really is not enough. Providing data and rushing expertise to the point of care, and this is whatever it needs to be. This is the Japanese principle, one of the few things that I really preach based on Toyota production. This old andon cord, you pull this cord, it's now a button, actually they got away from the cord, but the right people rush to you and in real time try and figure out why you're getting a sore shoulder from lifting the machine part that's coming at you at an angle that's not appropriate. And the same thing in healthcare. I found that people who are working in the research environment, such as you guys, you would go nuts if somebody called you up and said, we need your help. I think I threw away a line about an aerobiologist. So we had a chickenpox outbreak at Boston Children's that was very unusual, and we had 22 cases. What had happened was a girl had come in with chickenpox pneumonia because she was on corticosteroids for transverse myelitis. She was paralyzed due to chickenpox. and she was put in an isolation room, and subsequently cases occurred all the way down the hall, 22 total cases, even though she was in isolation. And I called up somebody, basically cold called based on what I read in the Harvard School of Public Health, who was an aerobiologist. And the aerobiologist came over with all of his equipment and helped me figure out that the ventilation system was broken, that the air was being forced out under the door and also out the window. We had at that time still had air conditioner type things. Went down the wall and was sucked in other air conditioners of other patients who themselves were on isolation for other diseases causing this outbreak, and we published it in New England Journal of Medicine. And he was happy as a clam. No one had ever called him in his ivory tower at the School of Public Health, working in the dark with his machines and his air and all that kind of stuff. So, you know, you guys are going to be thrilled if people call you. I'm sure you're going to rush to them and give them help. And Lucy will make sure that you have the time to do it. This idea of tolerating risk. So John Sterman, who's a systems dynamics guy at MIT, really smart guy, was on our scientific advisory group at Institute for Healthcare Improvement, and our innovation team presented and was talking about how proud they were that so many innovations they worked on had gone into production in the IHI products, if you will, webinars or whatever. And he said, so how often do you fail? And the answer was, well, we don't fail all that much. We're really good. And he said, well, you're not failing nearly enough. This is not innovation. If you're not failing 75, 80, 85% of the time, you're not really taking risk. You're not really innovating. He said the idea is to fail frequently, fail fast, fail well. In other words, learn from your failures and move on. And that requires a certain culture of safety, not like what I was describing in the laboratory a minute ago, but you have to trust the organization isn't going to be punitive. Celebrate reward, but also celebrate failure. So I was at this Vermont Oxford Neonatal Network, and I was looking at their posters, and it was something about communication in the ICU. And everybody's showing run charts, whatever, everything's improving, they're so proud of their work. I go up to this one group and I look at their chart, and it shows that their, whatever they were monitoring, had gone up and then it plummeted and it was below baseline. And I said to the woman who was presenting at the poster, I say, wow, this is really remarkable. How come you're presenting something where obviously you're struggling, so you've fallen below baseline? She said, I know, they told us we were here to learn. And that was a very moving moment. Here's somebody who'd said, this is a learning health system is learning. And it's not just bright spots. If I hear the word bright spots in quality improvement again, I'm going to go crazy. I am so sick of bright spots. I want all the dark spots to stand up. You have to embrace not invented here mentality, which is hard, but important. Now, this disruptive innovation, this is something that Clayton Christensen, who's at Harvard Business School, invented the term. He's been criticized for cherry picking and talking about bright spots, but I think it's a useful concept. So his first big insight was on something called rebar. It's a cheap kind of iron that's used to support concrete in buildings. And an innovator had developed something called a mini mill that could produce this very cheaply in small batches or whatever. And the steel makers all said, this is low-end stuff, we don't need to pay any attention to this. But over time, the mini mill people got better and better and started to go up the ladder of quality of iron and eventually steel products. And the high-end steel makers kept saying, not a problem, we got the good stuff. People always pay for the best stuff. But eventually, if all you're doing is producing the top-end stuff, it's really hard to sustain your business because everything else has been eroded and eaten away by the innovators. The innovation that changed my life was the transistor radio. Now, when I was young, I liked rock and roll a lot. And my dad had a huge mahogany RCA radio with glowing tubes in the living room. It was a gorgeous piece of furniture. It weighed about 1,000 pounds. And he wanted to listen to classical music and couldn't abide what I wanted to listen to. Sony had invented a transistor radio. It was pink, great boy thing. Man radio, pink radio. It was a piece of CRAP, basically. And as you'll remember, Japanese goods were thought to be cheap and unreliable and garbagey. But in fact, I could take this up to my room and play. I actually like doo-wop the most. I could play that all night long, and my dad would never know about it. And the piece was, it was not a very good radio, it broke and so forth. But they discovered a niche that they eventually developed in the Sony Electronics and ate RCA and Motorola Live, and those old radios don't exist. Positive deviance is another way to look for new stuff. Positive deviants are people in the organization who you may not even have noticed. It could be a housekeeper, it could be some quirky physician who always has his hair all mussed up and wears unmatching socks the way I did this morning. But he's got some wild and crazy idea that he's figured out how to do something even though you got this whole institutional structure that made it hard. This was originated in Africa around nutrition, where the investigators found that there were certain mothers, certain villages that had managed to get good nutrition for their babies despite famine and hardship and poverty. And they studied what those women had done and gradually began to spread that. The same thing happened with what's called mutilation, genital mutilation or female circumcision. This is something that culturally and religiously is just so embedded, but some mothers decided that their daughter weren't going to undergo that procedure, and gradually their ability to contravene social norms began to spread village to village until it became national policy in a number of countries. So very, very important. These brainstorms and hackathons, very popular. I've been to some of these. I think they're actually not that useful, because the problem is that people will find something that's really a pain point, something that's pissing them off, and they'll get together and have a hackathon to fix it, but they don't look at the pain point in relation to the whole system, and they end up with a point mutation kind of fix for the problem that doesn't do anything to improve the system. The winner in one of these hackathons recently was an app that brought together all the ways you could get vaccine for kids with all of our complex payment system. Well, all right, I mean, that's actually pretty novel, but the fact that you need an app and a hackathon to figure out how to get vaccine for kids in the United States is a bigger problem than MIT students developing something for a computer. Walk around and observe closely is really important. We were talking with a research group today about the importance of actually being on the front line. This is called proximity. If you want to understand diversity, race relations, the plight of lived experience of people in the United States of America, you got to get proximate. You can't sit in a boardroom and talk about, oh my God, we got disparities. The Japanese call this going to the gemba, going to the shop floor. Site visits, externally and internally important, borrowing shamelessly. Shadowing is really pivotal. There's nothing like following a patient around or going in the wake of a housekeeper to see what's happening, or even better, pretend to be such a person. The head of HR at Boston Children's dressed up as a housekeeper and went around for a day and came back in tears. She said, "I've never felt so invisible in my life." And ever since then, I've made it a habit, wherever I am, is to engage with and try and recognize the experience of people who are doing all of that work. And I'll never forget, there was a woman from the Philippines who was a housekeeper, and nobody could help me figure out how to get alcohol into the alcohol rub dispenser, that 3 of them weren't working on the ward, and I'm an infectious disease guy. And she said, "I will show you how to do it, doctor." And she was so proud that I was able to then do it, that I think it probably made her day. And that's kind of, you only learn that by, again, getting approximate. Ethnography is really important, and video ethnography in particular, and obviously including patients in this experience. And the video ethnography, KP, I don't know if it's really spread to your region, but my understanding is like 400, 500 people have been trained in video ethnography in KP, at least in the California region. And this is really useful at finding out what's really going on and painting a picture for the executives who probably don't spend much time at the front line or don't involve themselves directly in patient care. And the people who run this program at KP reminded me of Margaret Mead's expression, what people say what people do and what they say they do are entirely different things. So it's a multiplicity of techniques to find out what's going on at the front line. So now you have a promising, innovative idea from positive deviants and quirky people or disruptions or whatever. How confident are you that it's going to work in practice? And I don't need to tell this place, I should take these slides out, it's embarrassing. You guys are the Cochrane Collaborative in a lot of ways. But there's Archie Cochrane, who knows all the evidence on pipe smoking and is still smoking pipes. So what you know and what you do are a little different. And I want to caution you that despite all the evidence base and all the great work you do, you well know that most of the stuff we are thinking about to reform healthcare has really weak evidence base. And this morning I was actually reviewing the newest postings for the playbook that IHI has, Better Care for Patients with Complex Health Needs. And I have my whole evidence hierarchy based on grade and all this stuff. I'm pretty good at doing this. The number of interventions or models that have been promulgated to save us that have strong evidence is really disappointing. Not only is it very, very small, but the number that have been replicated beyond the originating institution is minute, and the number that have taken any account of disparities in the US healthcare landscape is nearly zero. So just a reminder that it's really hard to find generalizable evidence for major changes in healthcare. So a little apology for talking about Bayesian statistics, but some of you probably know this. It's really pretty simple. Bayesian approaches say, based on everything we know, evidence, experience, we have a prior probability that change X will work in practice. That's our belief. We can put a mathematical construct on it. We can give it a number. That's our probability that we believe this will work. Then we do a bunch of stuff called a learning healthcare system to find out whether or not it does work. And based on that experience, we constantly update our prior probability until at the end of our work, we have a posterior probability that's more precise and accurate. And that's what I think quality improvement in learning health systems are all about. It's refining and improving our prior probability using Bayesian methods. And if you explain that to pointy-headed academics, which you're not, I can tell you're actually a receptive, engaged academic, that gives it an authority that it probably didn't have if you're talking about it else in different ways. Show you something else from Clay Christensen, which I think is really important, especially for researchers. Clay developed this disruptive innovation, but he also, in an obscure paper, came up with this. So he doesn't know anything about IHI or the model for improvement. He's just thinking like a creative business person. He says, what we do in research is we develop a descriptive theory. This is observational research. We categorize and classify information, and we develop through our analytics a theory that gradually gets more and more precise as we understand the attributes of the phenomenon we're studying, and we get a preliminary statement of correlation, not causation, just correlation. And that's what we do in observational research, right? When we look at, analyze our large data. And what's interesting about this, he has predict and confirm. So he's saying, as we analyze our data, we're constantly having PDSAs, except in analytics, we're predicting and trying to confirm with the data that our prediction was correct. And the biggest thing on the slide is an anomaly. And what we do in health services research, just almost always, is to try and adjust away the anomalies instead of celebrating them and trying to understand why they occur. We don't want to mess up our theory, so we have this awful confirmation bias so that we can publish our paper in the New England Journal of Medicine. And he's saying, always challenge your theory, always challenge your theory. Then he flips to careful field-based research, which are clinical trials or whatever, but he's still saying, we're predicting, we're confirming, and we're looking for anomalies. And I've sifted through clinical trials a lot, looking for analyses that actually call out heterogeneity or anomalies, or look for why in a 20-country study of a new antihypertensive, it didn't work in Valencia, Spain, maybe because they just don't want to take it no matter how many protocols you have. But learning from the anomaly always is worthwhile. And that's part of the reason why so many things demonstrated by observational clinical trials don't necessarily pan out over the long haul. So really important observation. So let's now follow a concept from innovation to a prototype. A prototype is simply a reasonable facsimile of what will happen in practice. So a prototype of a car, you can imagine a Tesla. Notice we're talking here about degree of belief, not degree of evidence. This is Bayesian thinking. We have a degree of belief in the prior probability of the change we're going to make. And here we have innovations, and we're building a prototype which has its specifications, key concepts, measurement framework, and a theoretical predicted impact of that prototype, whether or not the car will actually drive on the street. We test this in one or two places. Let's say we test it in what's the name of that school that you mentioned?
Concordia.
Yeah, you test it there in Concordia's test bed. Most of these ideas don't work. In fact, that's my experience. Most innovative ideas are just, what's the expression? The dog won't hunt in the South, something like that. And actually, if I were being accurate here, all those stars would fall into the earth and only one or so would survive. But occasionally, one looks really good. The prototype really worked out in that one school, and now we're going to try it in 30 schools, which have different contexts, different environments, different socioeconomic and cultural and racial composition and so forth. And we're going to see what we can learn, and we're going to test it and revise it to really see if we can make this thing drive well. But it turns out that some of these don't work. They have to go back to the prototype and get completely redesigned. Others basically are never going to work outside of that our good friends school when we take it to schools where we don't have a good friend. And very rarely one of them is looking so good. It worked in different contexts and conditions. Now we're going to spread it nationally, or spread it even through KP. That would be an achievement. Even in one region of KP, we're going to spread the sucker, and we're going to do that. But even then, if you're really doing what Clay Christian said and looking for anomalies and challenging your theory, you may have to take it back to pilot testing and not just ram ahead like you found truth. Now, of course, the potential impact of context is really important. Where you do your implementation is critical. And so I'm going to tell you about Johnny Appleseed, who's an innovator, right? You know, you all know Johnny Appleseed, right? So actually, he was a bit of a preacher. He was it was called a new something faith that he was primarily interested in doing. But he also roamed the country, as myth would have it, and you see that sack, just broadcasting apple seeds wherever he went. And so we have orchards all over the United States. But in fact, he was a great innovator who listened to me give this lecture. And so he planted nurseries, not orchards. He felt that these were incubators for testing his innovation. So he fenced them so that livestock wouldn't trample them. He had neighbors looking out for him and watching the climate and seeing if a storm was coming. He returned every year to see what worked and what didn't work so he could refine what he was doing. So he planned with intentionality for sustainability in diverse contexts, exactly what an innovator ought to do. So what innovation did Johnny Appleseed not adopt to our misfortune? If I have the best, most delicious apple, and I take the seeds from those apples and I plant them, what happens?
Oh, do they not necessarily taste that delicious?
They don't breed true. They come up with endless variations. You do very rarely do you get anything that tastes like that really good apple. You get a lot of apples that are good for what? Good for cider. So Prohibition actually killed Johnny Appleseed's growing wealth because mainly people made hard cider from his apples. They were not eating apples. The way you propagate apples is grafting. So you find the good ones and you graft them on rootstock so that you continue to propagate it. So it's important that he was a great innovator and he did everything right, except there were people who knew that you had to graft in order to propagate the best apples, so he never really reached his potential. So even when you're really clear and you're doing everything right, you got to be aware of what other people's theories are for success. So here's just an example from, again, Gareth Parry on what happens if you don't adjust for context. So here you have some change which has gone through the initial gauntlet, and you test it in your friend's hospital or school, and it's 100% successful. I'm going to warn you here that you're going to see what look like confidence intervals or standard deviations. They're not. This is just the variation or range of contexts. All right, it's not a mathematical, just how different are the contexts. So you bring it now to some more sites where you're not so well known or whatever, and you test it now, it's 80% successful. You're starting to see the red dots, which are failures, and then you go to some more organizations, the context is getting broader and broader, and broader and broader and broader until it becomes a coin flip whether or not it works, because the context has changed so much and you have not adapted in any way to all of those different contexts. So this is what we generally do. Somebody has a great idea, the nurse-family partnerships, for example, and we spread it because the initial demonstration project was published in 3 journals, and now we've got it all over the country, and nobody's actually studying, believe it or not, whether they still work, and nobody's really thought about the context in which it's being practiced. So that's just a summary of that. And the question is, can you define under which context this innovation actually will work and where it won't, so that even with a lot of adaptation, you know, if I do this in Billings, it probably isn't going to work, but if I do it in 90% of the country, it is going to work. So being really honest about where you think it can be adapted to work and where you're pretty sure you can't adapt it to work is really kind of important. So the key here is to think about, this is a little bit geeky, technical specifications and core attributes of an innovation versus stuff that can be and must be adapted or modified according to context. Technical specifications might be infrastructure requirements or having supply chain. One of the studies that was recently published, not so recently, in The Lancet, showed that giving preterm corticosteroids to at-risk mothers actually harmed more women than it saved prematurity in babies, because the supply chain for determining gestation did not exist, and therefore people were giving steroids to mothers who shouldn't have them. So these are all important. I'm not going to go into any great length about them, but those core concepts must be executed with fidelity, regardless of context. Otherwise, the fundamental attributes that make this thing effective are just not going to happen. So a fundamental attribute of an electric car is it has to have batteries. And you really can't change that. You can adapt the design, put it in a wind flow tunnel or whatever you do, but if it doesn't have enough capacity to carry the batteries, it's just not going to be an effective car. But the rest of it can all be adapted to a local context. And here's a concrete example. You've probably heard of rapid response teams, otherwise called medical emergency teams in Australia, where it was developed. The idea here is grandma is going south. She's deteriorating on the ward. She looks like death warmed over, and in fact is death warmed over, and you want to intervene as soon as possible because otherwise she's going to die. And so somehow, somewhere, you have a system to alert a rapid response team to come to her rescue, and they come to the bedside, they assess, they intervene, and save her life. The key here is that the specifications for what this rapid response team should do should be as broad as possible without being so broad that they're meaningless, and not too narrow so that if you really have to do this, you're almost never going to be able to marshal the supplies and the people to do it. So what are the specifications? So here's one: a reliable method for anyone to identify the deteriorating patient in real time. This can be a parent, this can be a nurse. You can use, as I've indicated here, the Muse score, the Pews score. You can have using all the data in KP, an automatic detection system. Baylor actually has such a thing. But a family member's suspicion is good enough if you don't have all that other stuff. So the core concept is rapid identification and alerting functionality regardless of the method used. The next one, you have to have the right people arrive to actually do the assessment and to intervene. And in the original systems, it was an ICU nurse, a respiratory therapist, a physician. That's terrific, but let's say you are in Bismarck or Billings or some acute care hospital in rural America. There's no way you're going to have those people there. The question is, can I do what I need to do? Maybe it's just putting a pen through the cricothyroid membrane and establishing an airway. That might be done by a paramedic, by one physician, even by a highly trained nurse, but you have to have the equipment there to do it. And again, the equipment can maybe just a sharp object, or it may be a full set of sized endotracheal tubes and apparatus. So I don't know if I'm making this as clear as I could, but it's not too specific, not too broad so as to be meaningless, and then anybody can adapt to meet those technical specifications. It's amazing how often people cannot describe this. I was on a visit to Northumbria in England with an innovation that had failed to spread, but everybody thought was the greatest innovation ever. And when I asked them, they were celebrating this and they showed all their data, and I said, so it's not spreading, what are the technical specifications that must be replicate it with fidelity in other centers, and what are the parts of this that you think they can adapt any way they want? And they couldn't even begin to answer the question because they'd never thought about it in that way. I'm not going to go over this because it's too much, but if you look at the slides, you'll see that a lot of what we do is wallowing in context and complexity. I was telling Lucy that at the dissemination implementation meeting in Washington, where all these people get together, I looked at well over 100 posters, and almost all of them were wallowing in context. The frameworks for context, evaluations of context, and I saw literally no posters that showed dramatic improvement in a way that I could recognize. So we can't wallow in it, but we also have to understand it. And when you have a chance, you'll see I've given you here frameworks, especially the CEFR framework, Consolidated Framework for Implementation Research. And what you're going to conclude when you've looked at these, and I hope you will because it's kind of important to understand these things, it all goes back to the same stuff. Everett Rogers and early adopters and what he had to say about how you know whether or not an innovation will spread. This is all the same stuff being reframed in different ways and with increasing complexity, if you ask me. So, but you do have to have a plan to assess context. And I've got the attributes that Duke uses. I'm working with Duke. That's for your future delectation. I want to just emphasize the way a friend of mine, David Hamer, does this at Boston University. Because one way that we do it in improvement is say, we're going to do our intervention, and as we go, we're going to look at the context, we're going to adapt according to the context that we find. And we waste a whole lot of time in real time trying to understand the context and do our adaptation. David Hamer, who's a clinical trialist, had a different idea. He wanted to use or study chlorhexidine, an antiseptic, applied to the umbilicus of newborn babies in Africa. And he wanted to see if it works. WHO guidelines were to use chlorhexidine. And he wanted to do a pragmatic trial to see if this really worked. And he said, I can't afford with my budget from USAID to wallow in complexity and analyze the context and adapt as I go. I have to know how to implement this according to the context I'm likely to encounter. So he did ethnographic research, going village to village, chief to chief, talking to people about what it would be like to have chlorhexidine applied to the umbilicus of a newborn baby. And what he found was that in some areas and cultures, going into the dwelling to put this stuff on was a curse forever on that baby. And the baby soul would fly away, and it was the doom of the baby. When he was all done studying context and implementing according to the context he knew existed, he got, as I remember, 93% implementation in a very large clinical trial of this intervention. And he demonstrated that it didn't work. So there was no cherry picking here. There was no, it worked in these contexts, it didn't work. Everybody implemented this, and he could tell you precisely where it worked and where it didn't, and overall it didn't work. So I really recommend that, is to not wait to start to look at context, but spend some time really doing ethnography and qualitative research. Look what happens if one ignores all of this about technical specifications and context and planning ahead. Is anybody familiar with the surgical checklist? Do you know what that is? Surgical safety. So Atul Gawande, great man. He's now, Bezos has given $1 bazillion to reform U.S. healthcare, but he actually has a place called Ariadne Labs in Boston. I go to his conferences. So he did a study in 8 hospitals around the world, and everybody thinks it was a randomized controlled trial. It was not. It was a trial in which he implemented a surgical safety checklist in these 8 institutions and followed to see what happened. There was no counterfactual. There is no comparison group. How the world, even I, in the syllabus for my school public health course, inadvertently called it a randomized trial when it's not. Anyway, it was incredibly successful. He got published in the New England Journal. I've saved lives. Complications are down. The surgical safety checklist is great. So policymakers in Ontario, Canada, said, this is great. Everybody should do this. And they passed legislation that every operating theater in Ontario had to use the surgical safety checklist. They could modify slightly, but it had to have the core elements. And when they were done with this trial, they found a implementation rate of, I think, 97%. Well, you know that's garbage, right? Anybody who's done any surgery or knows surgeons knows that implementing the surgical safety checklist and getting 97% is crazy. Maybe they check some boxes, but the checklist is all about communication, planning for unexpected complications. It's all about what you do with the checklist. There was no training to implement it. It wasn't phased in. It was just plopped down on the health system, and despite 97% implementation, there was no impact. And so that was a prime example of something that under protocol conditions appeared to work, but when disseminated widely without due respect for phased implementation and context, absolutely failed. And the same thing happens with a nurse-family partnership, which everybody thought was the greatest thing ever because of 3 trials in the United States. The National Health System tried this in England, and it showed no impact. The reason it probably showed no impact there, what's the usual excuse? You didn't measure the right thing. That was what they said. In fact, the NHS provides such good care postnatally that the marginal impact of this was not discernible. The Peter Pronovost prevent central line infection stuff, they tried to replicate that in England in the NHS. No impact because when qualitative research was finally done on what happened in Michigan, where the study originally was done, none of that was done in England. The context was different, the culture was different, so it bombed. So I guess the bottom line is finding the innovations, doing the proper testing, understanding the role of context, and spreading with great intentionality is really, really important. And it's hard, takes time, it's expensive, but it's really expensive to have a national rollout of something and have it fail. It's really the job of the innovator to describe, based on the initial testing and the testing usually in an expanded group of sites, what they believe to be the technical specifications. And they're subject to revision. It's like every logic model is a living document. Every list of technical specifications, at least early on, ought to be revised. But by the time you're ready to scale, you ought to have a great degree of confidence that if you don't do these things, you're probably going to be unsuccessful. But they ought to be, as I said, as broad as possible without being meaningless or watered down. And another thing just to think about, if there are 30 of them, it's too many. Okay, it should be parsimonious if possible. The norm, which IHI does all the time, is to get an expert group, put together a change package, we call it, or a bundle or something like that, run a collaborative and adapt it based on the context that we encounter. And we don't do a particularly rigorous job of evaluating those contexts, in my view, because we are not set up to do that. And as you say, it can be expensive and time consuming. But ideally, and one of my, I don't know, not quite a dream, but something I'd like to see, I think that actually most important contextual factors can be specified for evaluation. And what do I mean by that? There's a colleague I have who's trying to get his PhD, and he's looking for themes using qualitative research and whatever. And I said, do me a favor, get a piece of paper and write down the themes you predict you will find at the end of your research. Put it in an envelope and we'll look at the end. And my theory is that we know 80 to 90% of the themes we will find, and we're basically going to confirm that. So what if improvement advisors, the people in the quality improvement department who are helping the teams evaluate and improve, what if they went in with a scale of 1 to 10 or 1 to 5 for the 8 themes, and then they can always ask the team, and is there something else that's accelerating or impeding your progress, and then make a note of that. And we begin to develop a quantitative way in a rough form of adding that data to our model or our analytics. And I think that's a way to get more efficient. In these big projects like this USAID project, which probably costs millions of dollars, if not more, spending that time is really important. And you don't have to go to every village and every chief, but you really have to sample so you know what you're getting into. I thought it was a very efficient and cost-saving thing to do rather than scrambling when you find, oh my God, the implementation rate's 57% in North Ethiopia, what are we going to do? You know, and then you come in and you bludgeon your implementation, and then it doesn't generalize. Yeah, I mean, this is the beauty of I think, Bayesian thinking. So whenever we do this in an organization, let's say, or in a collaborative, if people are rigorous about that and honest, they should have the point estimate of their attributable impact and confidence intervals. So I think the attributable impact is 5%, confidence interval is 1 to 9. Which gives you a sense of your degree of belief. And then as you do your testing, you ought to begin to understand whether that's accurate. Now the problem is that the outcome often is not measurable in real time, right? And so that brings in another degree of belief as to what extent do you think that this process measure is closely linked to the outcome you want to achieve. What's your estimate of that? And it can get pretty impossible after a while, but at least forces you to think about whether this is really tightly linked or pretty squishy. I have the same attitude when people want to suggest projects along a major driver of change. Let's say it's, I can't think of a good one, but build interprofessional teams at the point of care is your big driver to get better outcomes for people with dementia. So you can measure using some survey on teamness whether or not you're accomplishing that. But my degree of belief that teamness is directly related and linked to lower bad outcomes from delirium is pretty squishy. I mean, I have faith in that, but I can't prove it. On the other hand, if it's, I'm going to have a process change in which I get patients mobilized and off sedation by such and such a day, and I think that'll affect the outcome of delirium, that's probably pretty tightly linked. I'm pretty confident if I can show that my estimate of the impact on delirium outcomes will be good. Yes and yes. No, I don't go to the quality improvement literature because you won't find in any literature I've ever read. Maybe Brent James talks about this, I don't know, but I don't know anybody. I think because I'm an epidemiologist, I think that's really important. And in terms of a dartboard, there is an evidence base for most of what we do, and if the evidence base really stinks, and nobody's ever tried this before, then you ought to have some estimate that's your best guess, but it's going to have really wide confidence around it, confidence intervals. So yeah, in that case, I'm guessing. One of the things, the reason I sort of wanted to show that epistemology, how we know, is that the lowest level of knowledge is we don't even understand how to characterize the thing. So in diabetes, oh, the sweet urine, they're dying. Literally, people taste it, the urine, they're dying. Very low level of knowledge. Now we understand the impact of blood pressure, control lipids, we have servo mechanisms, and blah, blah. We have a very high level of knowledge. So our ability to predict is really much better than it used to be. And a lot of our changes are no better than the urine sweet, and somebody thinks this will work. Yeah, there is. I'm not even that much of an expert on it, but I think that's some of the contributions that I didn't go into of Rogers and others, trying to define those characteristics which predict whether or not a innovation is going to be adopted. It has to have a clear relative advantage. It has to be integratable into the work that people do without total revolution of how they provide care and so forth. So I think you can give a rough prediction of whether the dog has a chance in the race. In terms of the ethnography, this is a really critical, I am definitely opposed to cultural competency as the defining characteristic, because it invites us to stereotype people and according to whatever construct we have. Really good ethnography, and in fact what I like to call cultural humility, implies that my main goal here is to understand the lived experience of this individual so that we can have a dialogue about things that are important to them. That's a different kettle of fish. I think David, when he went out, was not, I hope, in his mind thinking these primitive villagers who have this crazy notion of spirits. I'm just going to find out about that so I can figure out how to manipulate them. But rather, he was curious as to what it would be like to do what he was thinking of doing in that population. And I don't know what he did, but I imagine he worked out some agreement where it wasn't done in the house and whatever. But it's a vital point, and the less diverse your organization is, and I know that we're not in the most diverse community in that we might be in, the less diverse the community is, the less you're likely to appreciate how difficult it is to get to know the lived experience of people in a respectful way. The hardest thing I do, we have finally at IHI a diverse organization with I'd say getting on a community that sort of reflects the community we serve. And every day for me is a learning opportunity, talking about learning health systems, to figure out how I can respectfully understand better the people with whom I'm working with so I can support them rather than piss them off. But it's hard, it's really hard. And if you don't have, I mean, it's not the most diverse room I've ever seen, to tell you the truth. And it just makes it all the harder because it's like everything else. But humility is the right word. I found, and I'm sure I'm not good at this. If you ask people at IHI, I'm hardly stellar. But I always start with a position of humility, like, you know, I'm going to screw up probably here, but I'm going to do my best. And I'm hoping, trusting that you'll tell me when I'm saying something that it just isn't the right thing. And people like that. They do tend to respond to that if invited.